The first year we traveled through the journey of dialysis in terms of machines, alarms, common problems, more of a theoretical based discussion, and we ended up with a good interaction with the dialysis personnels. In the second year, we strengthened those topics to a next level where we try to highlight more practical issues and also increase the time for discussion. This time, in the third year, what we are focusing on is to make it more clinical rather than making it more theoretical. So we are trying our best to get in some clinical case scenarios, possible videos, so that you are able to see that how you will be seeing it in your unit. And the topic chosen this time was neurological complications in dialysis unit, secondary to a couple of cases which happened in the last 2 or 3 weeks. And it helped to trigger the point that these things are also equally important as we discuss other topics. So when we look at neurological problems, we know that we are talking about the brain. And we talk about the brain, we need to know some names: the frontal lobe, the judgment, assessment, the parietal lobe, sensations, temporal lobe, speech area, occipital lobe, something related to our eyes and occipital visual area. You've got cerebellum, which is looking at the stability of the body, and spinal cord, which carries those nerves down. So these are the common lobes which we have in the brain. And when we talk about the human nervous system, we speak about there is a central nervous system and a peripheral nervous system. Central nervous system, we discussed that it is about the brain and spinal cord. When we talk about peripheral nervous system, we are talking about the nerves of the body. And when you look at that, it is divided into sensory and motor. We all understand that sensory means sensation, motor means power. That is basically the muscles. So basically carrying message from the sense organs and the internal organs to the central nervous system, and motor, which takes care about the organs, glands, and muscles. Then we talk about these two words, that is autonomic nervous system and somatic nervous system. When we talk about somatic, it is basically to those muscles which are under our control. And when we talk about autonomic nervous system, which is very important for us, where we talk about the two types, sympathetic and parasympathetic. Sympathetic means in any term of a situation of an emergency, the body reacts. Suppose a lion comes in front of you, you will run the fastest ever you ran in your life. That preparedness of the body for emergencies are created by the adrenal influx of the sympathetic division. And the parasympathetic division controls the body during non-emergencies to keep the poise in control. So these words will be coming on and off in these discussions. So that is why I just wanted to introduce these words to you. As Sir said, when you look at neurological complications of patients undergoing dialysis, it's a long list, starting from something like central nervous system issues like dialysis dementia, disequilibrium syndrome, Wernicke's encephalopathy, that is secondary to thiamine B1, vitamin B1 deficiency, central pontine myelinosis, secondary to rapid correction of sodium. So if the sodium is corrected more than 12 a day, a fast rapid correction, both sides can cause pontine myelinosis, and which can lead to further seizures, coma, and the patient may die. But something like uremic encephalopathy. So you're talking about the patient where you're discussing the patient has got high urea levels and uremic symptoms, which is affecting the brain. The patient is disoriented, confused. The patient can have tremors. You've got cerebrovascular disorders, whether you've got an atherosclerotic ischemic stroke or whether it's a hemorrhagic stroke, possible in dialysis patients. You get something called as posterior leukoencephalopathy syndrome. The name is shortened as PRESS. So what are you looking at here? Basically, a very high blood pressure creating a confusion in the mind of the patient, leading to seizures, involving the classical neurological picture on CT showing MRI showing occipital involvement. Posterior involvement is basically what we're looking at, posterior leukoencephalopathy, and also when you come to the peripheries, you got peripheral neuropathy, whether it's a single nerve mononeuropathy or it's a polyneuropathy, it's a mixed nerve disorder. Patients can have simple things like headaches, autonomic dysfunction. Patient can have muscle involvement, myopathy, chronic pruritus, complications secondary to mineral bolt disorders, that is vascular involvement because of this high phosphorus, high parathyroid hormones, secondary to which it can lead to decreased blood supply to the nervosum, which is supplying the arteries and the veins and even the brain. Sleep disorders, And last but not least, but which we often hear from patients about restless leg syndromes. There is a pull, there is a catch. I feel like worms are walking on my legs. I'm not able, I'm always shaking my legs. There's a lot of cramps. All these things as a whole is what we are is involved in neurological complications in dialysis patient. Very surely we cannot cover everything of this, but still the common ones which we see will try to cover. But before that, we should know what are the risk factors and how we can identify those patients who are at possible risk of getting this problem. So when you look at shared risk factors, the common risk factors, you're talking about patients who are an elderly age, non-white race or low educational status, diabetes, hypertension, comorbidities, which can cause direct impact on causing neurological problems. People who have got hyperlipidemia, atherosclerotic disease, genetics, another. And in nephrogenic risk factors, that is kidney-related risk factors, you've got patients who got high albuminuria, patients who are very anemic, patients who have got not adequate dialysis, so there is retention of uremic solutes, patients who have got inflammation, vascular calcifications, hyponatremia, there is electrolyte disturbances. Patients are who are on erythropoietin stimulating agents. We know that if they are on ESAs and with high hemoglobins, the chances of increased cerebrovascular accidents as seen in CREATE and other trials. All these causes can combine together to give neurodegenerative disease, or they can cause something called as a microvascular disease in form of stroke, or they can cause direct neuronal injury or directly increase the risk for stroke. And all these multiple problems can eventually lead the patient into cognitive impairment. So each part of this is important. So when you face a patient with elderly dialysis patient or with all these risk factors, you know that when this patient complains of a certain neurological symptom, you should be more alert in those patients. So let's start with case one today. So as discussed, 69-year-old male is a known case of chronic kidney disease, end-stage renal disease, secondary to diabetic neuropathy with creatinine of 18 and urea of 256. He was advised initiation of hemodialysis. He has been long prolonging the dialysis and eventually agreed for the same. He underwent 3 hours of hemodialysis in the first session and was shifted to the ward. After shifting to the ward, initially he complained of nausea and he had 2 bouts of vomiting. He also had a single episode of seizure, so he had a little bit of seizure as well. The consult doctor advised injection lorazepam 2 milligram bolus and also gave an anticonvulsant levetiracetam 500 milligrams to control the seizure. He then developed irritability, aggressive behavior, and then he was behaving disoriented. By the time blood investigations, arterial blood gases, CT brain was done. In the blood investigation, we had a urea of 65 milligrams per dl, a creatinine of 6.9, sodium was normal 135, potassium was normal 4.2, calcium was normal 8.3, magnesium was normal 2.1, and also the CT brain had no significant findings to show in the beginning. So where are we and what's the diagnosis? For a 69-year-old male who underwent the first dialysis 3 hours with following which he had seizures, irritability, disorientation, and the following report showed urea of 65 and a creatinine of 6.9. What we distinctly see in this case is a patient's urea, which was 256, after the first dialysis has come down as low as 65. So there is a sudden shift of hyperosmolar blood to hypoosmolar because of loss of urea. So what does it cause? Yes, the first thing which we commonly encounter in our dialysis initiation, dialysis disequilibrium syndrome. Patients with constitution of neurological signs and symptoms which are attributed to cerebral edema during or following intermittent hemodialysis or continuous renal replacement therapy. Patient usually presents with headache, nausea, dizziness, confusion, visual disturbances. Some people have tremors and lately seizures and then can go to comatose state. Slow onset gradual removal of urea while initiation of dialysis is the most keen important point we learn for preventing dialysis disequilibrium syndrome. Generally, we always keep the blood flow between 150 to 200 ml per minute. We may, in such patients who are elderly and with such high urea, which is above 150 to 200 milligrams per DL, it is ideal to go for a initial dialysis of maybe 2.5 hours or 1.5 to 2 hours, and then 2.5 to 3 hours on day 2, and maybe on day 4 or 3 go for the complete 4-hour duration dialysis, and gradually then thereafter increase the blood flow rates as per the axis. So what really happened in this patient was, as you see this cartoon, you got the blood vessel in red, the brain cell in cream color with equal number of urea molecules, or what you call urea particles. After dialysis, from the blood, the urea was removed drastically, but the blood-brain barrier on the other side, the brain cells had equivalent amount of urea. So from a hypoosmolar state to an hyperosmolar state, the water pushed from the blood into the brain cells, and you see the size of the brain cells, they swelled up because of cerebral edema, and that resulted in the patient having those symptoms. The risk factors for dialysis disequilibrium syndrome are: first dialysis treatment, children, elderly, patients with high urea nitrogen, hypernatremia, hyperglycemia, metabolic acidosis, pre-existing neurological abnormalities, pre-existing cerebral edema, conditions associated with an increased permeability of blood, and patients have some sort of leaking blood-brain barriers, patients who are on CNS tumors or malignancies, and others. So, what are the potential strategies we can do to prevent dialysis disequilibrium syndrome in these high-risk patients? You should limit your first dialysis session to just 2 to 2.5 hours. You should limit the blood flow around 200, 150, 200 to 250 max. Sodium remodeling is very good. If you have high sodium in the blood, it will help you in maintaining the osmolarity of blood in spite of urea being drained out. Even some situations they consider to increase the osmolarity, they give intravenous mannitol. They consider CRRT in patients at high risk of DDS. Suppose the patient has got a traumatic brain injury or intracerebral hemorrhage or any mass lesion. So in patients in places where we have CRRT facility, that should be opted first. So after moving from case 1, we go to case 2. 45-year-old male, a known case of IgA nephropathy, was undergoing dialysis and he developed headache after 2.5 hours. So around 2.5 hours to dialysis, he developed headache. The sister noted the blood pressure as 180/110 millimeters of mercury. The instant response to relieve the headache was to give IV paracetamol and to decrease the blood pressure, hoping that the pain in the head is secondary to the blood pressure. Sister had administered half the tablet of antihypertensive nifedipine retard 20 mg. His dialysis was continued and he further complained of blurred vision, and eventually he developed a seizure. So you must note the events that it started with an headache, was given some medications to relieve the headache, and also something to decrease the blood pressure, but the patient continued to have symptoms, blurred vision, and a seizure. So when he had seizure, his dialysis was stopped and he received urgent medical attention and was shifted to ICU. In ICU, he became drowsy and he had repeated seizure episodes. The intensivist there intubated the patient and made the patient hemodynamically stable. Some NTG infusion was started to control the blood pressure. A Riles tube was put and he ordered a plain CT brain. So from these symptoms of sudden onset headache, followed by blurring of vision, then going into seizure, and then patient repeatedly falling into drowsiness, and then eventually getting intubated, what will be the probable diagnosis here for us? Or let's see what the CT brain showed. As we expected, the axial cross-sectional CT image of the brain in an hypertensive patient showed a massive intracerebral hemorrhage. You can see this as a white spot on the black background. In the right temporal lobe, with decompression extension of the hemorrhage into the ventricular system. So this was the ventricular system here. You can see that there is swelling around the hemorrhagic area, which has pushed this particular X should be in the center. It has pushed the midline of the brain to the other side. There is massive extension of the hemorrhage into the ventricular system. There is a severe mass effect with brain herniation. And you can also see a small hematoma subdural on the left side. So this was the finding in that patient. So when we deal with intracranial hemorrhage, the dictum is to stop dialysis, stabilize the patient on CT, then depending the amount of hemorrhage and the involvement of the brain, patient is further taken for hemodiafiltration or CRRT depending the center or SLED in non-dialysis centers when required, and if can be decompressed, then they go for the same procedure, and then eventually later on once the patient is stable, they go for hemodialysis. In patients who are having small hemorrhages can be managed conservatively. We have to stop all the antiplatelets, all the anticoagulants, and if the patient was administered heparin, then must be considered to be reversed by using protamine sulfate. Also important is to maintain the blood pressure around 150/90, 160/90. You should not bring it too low to maintain the cerebral perfusion pressure. Similar scenario of patients where they can present also as a cerebrovascular ischemic infarct, where you get an ischemic stroke, where the problem is the blood circulation has reduced due to an atherosclerotic embolus in the main arteries supplying the brain, or a thrombus formation following the plaque. So these patients are those who are having diabetes, hypertension, smoking history, long dialysis history, patients who are having hyperparathyroidism, hyperphosphatemia, patients who have got hypoalbuminemia, which increases the thrombotic state. So these things, patients are at risk of also getting what is called as an ischemic stroke. The imaging is important in these patients. So CT or MR brain should be taken. Always remember that if you are aware of the onset of symptoms, suppose the patient had the symptom in front of you or the patient's bystander tells you the history that it is within the first 3 hours, which is considered as a golden hour, then patient can also be taken for thrombolysis, which can eventually reverse the stroke and the paralysis. So it's very important that timely action to understand the disease, to understand the symptoms, and initiate the evaluation early so as to give prompt treatment to the patient. Eventually, then to explain them lifestyle modifications. So basically, when you look at kidney and cerebrovascular disease, it's like an axis. It's a on-running thing. So whenever it can be based on genetics of the patient, patients with hypertension, diabetes, smoking, arterial stiffness, as we mentioned, it causes more oxidative stress, cerebral blood flow impairment, chronic inflammation, and then accelerated atherosclerosis, and finally it can lead to strokes, which can be large vessel, small vessel, or it can lead to, as in our patient, as an intraparenchymal hemorrhage. So what are the things we want to remember from this case? Headache can be of any cause. So mild headache, major headache. Headache is a symptom which can mean anything, and hence prompt BP measurements and neurological signs should be looked into. In this patient, the main neurological sign was his blurring of vision and also inequality in the pupillary size. So when you put a torch into the eye, you may find a pupil is small and the other side pupil is large. There's an inequality in size, a very good indicator to the side of possible bleed. We need to stop the heparin infusion. Here the patient was continuing the dialysis. You have to stop the heparin infusion and analyze the patient as well as stop the dialysis. Use protamine to neutralize the heparin. We all know that 1 ml of protamine sulfate will neutralize 100 units of heparin. And also very important was to monitor the vitals. The timely intubation, timely hemodynamic parameters to be assessed, kept the patient alive in such a serious condition. So we have to, in case if it's under not your control, the patient is not doing fine, you have to call for code blue and ask the team to come in to help you out. And till that point, you have to give umbu respiration and maintain the vitals and keep the head turned to a side so that the vomitus of the patient does not aspirate and get into another problem. So this is what we learned from case 2. So now we go to case 3. So a 62, he was undergoing dialysis and suddenly he noted jerky movements of both the legs. So he didn't have any other neurological deficit. He didn't have seizure activities. So once again, a patient who was few days complaining about sort of drifting to some side and now has a sudden jerky movements of only the both lower limbs. And he did not have any other neurological deficit. He did not have any seizure activities. So let's watch the video. So this is a video of that patient where you can see that both the legs are moving equally, dysynchronous. They are not synchronous, different muscle planes like. So basically, this patient had extrapyramidal symptoms. So what is extrapyramidal system functions? Basically, it helps in regulation and integration of voluntary motor activity. So whenever there is a dysfunction, there will be either rhythmic and regular movements like tremors, or as in this patient, we had dysrhythmic and irregular movements like a chorea, acidosis, or dystonia. What you have to remember that is abnormal movements is secondary to the control loss of the extrapyramidal system. Regulation and maintenance of muscle tone, when it is lost, these patients can have rigidity and hypertonia. So this patient was moving towards the left, a little drifting because of the intermittent rigidity which the patient was feeling in the legs. Regulation and maintenance of emotional and associative movements. Certain patients will present like Parkinsonism. So they will have bradykinesia, that is a small walk. They will have a mask-like face. Whether you are happy or sad, the face looks the same like a mask. They will have very infrequent blinking. They will not blink at all. They will lose. They will walk with stiff hands. They will not swing their hands while walking. So any of these symptoms which you see, possibly you are dealing with a patient having extrapyramidal symptoms. And these patients are usually treated with benzodiazepines and anticholinergics, and you'll see an impact improvement within few days. So this patient had underwent a CT brain, which was normal. He had underwent EEG to rule out any seizure activities, and again that was normal. And basically, the patient was started on a benzodiazepine clonazepam 0.5 milligrams, and the symptoms improved by the week, and he was continued on the same for the coming months. The next symptom which neurological thing which we are going to discuss is about dialysis dementia. Dialysis dementia is a form of dialysis related encephalopathy that is associated with dyspraxia and multifocal seizures. So unlike dialysis disequilibrium, where we always talk about dialysis dementia, which is really slow compared to dialysis disequilibrium, which is very fast. And it can occur in hemodialysis patients for at least 2 years, who have been on such a long onset. And mainly it was believed that there are three types of dialysis dementia. One, which is because of an epidemic, which was because of the contamination of dialysate with aluminum, which is not common now. A sporadic endemic form, which was unclear, the reason of which was not known. And the third in the pediatric group, because the medications given to pediatric children were containing a lot of aluminum. So basically, these were the types of dialysis dementia noted. Another entity which would like to highlight along with this is an uremic polyneuropathy. So patients with uremic polyneuropathy, they present with sensory symptoms like tingling, burning pain in both the hands. Basically, it is symmetrical. It has got sensoromotor both involvement. And in advanced cases, they can have even myoclonus and paralysis. They can have muscle twitching. What is more important, why is this uremic polyneuropathy existing, is because of high uremic toxins. So the adequacy of dialysis has to be maintained. So in these patients, we have to increase the duration of dialysis or the number of dialysis in the week. We can use better dialyzers to and check on the pre and post dialysis urea reduction ratios and KT by V to see whether the patient is getting adequately dialyzed. Medical treatment, gabapentin, carbamazepine, and antidepressant duloxetine. These are the three drugs which are commonly given for these patients. One after another is tried, and with which the patient feels better is continued. Other drugs like phenytoin, topiramate are commonly used for the same. This is another condition. Here, this is a case of a 58-year-old man who presented with left upper extremity steal syndrome, including mainly a ischemic monomelic neuropathy. You see this hand of this patient. The basic thing is what you see is like a claw hand. There's complete loss of function and there is contractures in this fourth and the fifth digits are bent already. There is a contracture there. And when you were examining neurologically, there was loss of sensation in the distribution of the ulnar nerve, that is on the median aspect. So the patient had rest pain, patient had complete loss of function with contractures and the of the fourth and the fifth digits. So basically, this patient, because why is it happening? It results because of the blood flow alteration to the nerves, the vessel which supply the nerves, which nerves, median nerve, radial nerve, ulnar nerve in the hand, which produces the claw hand actually. Mostly it is irreversible, but there are cases which have been reported where they were able to close the axis and reverse the patient's many neurological problems because of appropriate strategy and early intervention. Absence of severe tissue ischemia. So what happens? How do you differentiate this ischemic monomelic neuropathy with Steele syndrome? So the idea is basically to tell you that when you have a Steele syndrome, you will have discoloration of the digits with indication for tissue ischemia. That will be very severe. Here, the patient does not have tissue ischemia. It's mainly because of the nerves traveling to these muscles are affected because of the alteration in the blood flow to these nerves and resulting in muscle weakness as well as presenting as a claw hand to you. So remember this sort of contractures and weakness of the single limb is very in the vascular axis area is very important to understand that the patient is having something like ischemic monomelic neuropathy. Next in the picture, we are discussing about restless leg syndrome. So this we are talking about the only common things. Rest all we'll do in discussion. So the restless leg syndrome, basically, patient will complain of aches, pulling in the legs, itching in the legs, sensation of bugs under the skin. Very recently, many of the units must be knowing about this, that they were having patients complaining of as if some insects are crawling on their skin. There is tingling sensation, there is tightness, there is electrical or something like a jolting sensation. All these symptoms are common in restless leg syndrome. So not only about aches and pulling, but also about the sensation of bugs, tingling, and electrical sensation. That is what mostly common patients present with. And basically, they can be primary or secondary. Primary is commonly because of idiopathic, or maybe there's a different postulates. They say that there is because of iron, excess iron in the blood, causing cerebral iron deposition, and there's dopamine system dysfunction. That is the two things which they highlight, and more of the increase in the glutamate levels in the blood and deficiency of certain magnesium and folate, and certain common comorbidities like diabetes, amyloidosis can present with the same. Certain drugs can cause similar symptoms like antidepressants, antiemetics, antihistaminics, and antipsychotics. So for this, the mostly the drug of choice is ropinirole, which is given for almost 54 to 75% improvement in RLS. These two drugs, ropinirole and pramipexole, is commonly used. Generally, all physicians write gabapentin, which we all are aware of for any sort of muscle aches and pain in the legs. They start the drug. And mainly where you find that there's a dopamine deficiency, then we consider the drug levodopa also in these cases. So we had looked into the cases from central nervous system, we looked into the peripheral nervous system, we looked into some common nerve related problems. What will be the end result to all these things? The end result to all these problems is the cognitive impairment in hemodialysis patients. So chronic factors with low brain reserve, with systemic vascular hypertension, diabetes, homocystinemia, inflammation, brain tissue specific beta 2 microglobulin accumulation over a period of time, soluble proteins and oligomers, apoptosis, chronic encephalopathies or a neurodegenerative tauopathies, incidence of increased strokes, transient ischemic attacks, causing delirium, acute events, cerebral events, all these things. And also, it's not only about chronic, but also acute factors which are associated in the dialysis process, like drop in intracerebral blood pressure and perfusion, time in and again there is hypotension to the patient, acute ischemia, cerebral hypoxemia, causing brain edema, or systemic infections causing hypoxemia. All these multiple insults which a hemodialysis patient has to undergo over a period of time leads to chronic cognitive impairment in these patients. So it is very important that we minimize the amount of variations in blood pressure, the chances of early pickup of neurological symptoms to avoid chronic complications. Treat the TIs as very early markers of strokes and try to add on medications which will prevent the possibility of stroke in these patients. Use the ESAs, that is your erythropoietins, very cautiously to see blood levels of hemoglobin and not allow it to go above a certain level, which will increase the incidence of strokes. And also have a clear-cut idea of what medications the patient is on to rule out many of the neurological symptoms like increased sleepiness because of gabapentin drug. There are many other drugs which cause neurological disruption, which has to be also looked into. So coming to a final slide, which covers most of these central disorders which we mentioned about dialysis, dementia. We spoke about avoiding aluminum phosphate binders. There is a treatment now which is desferoxamine is the antidote for the same, and benzodiazepines can be used. Patients which we discussed on central, second was about the dialysis disequilibrium syndromes, where we mentioned about slow hemodialysis, high dialysate sodium levels, and osmotic active agents so that we can prevent the blood hyperosmolarity, to maintain the osmolarity of blood, to prevent edema of the brain, and to go slow on the hemodialysis to begin with. We spoke about uremic encephalopathy and we said that adequacy of dialysis is very important. Ultimate treatment would always be renal transplantation. We did not discuss about Wernicke's encephalopathy, but generally these patients are because of vitamin B12, B1, that is thiamine deficiency. They'll end up with neuropathies, global confusions, ataxias. These are the presentation. Ataxia means they just wobble when they walk. You may have seen that many of the nephrologists advise giving thiamine injections post dialysis to patients who generally complain of all these multiple disorders. Hemorrhagic cerebrovascular disorders, we discussed this in detail. We spoke about the bleed in the brain, headache, symptoms of convulsions, blurring of vision, having inequality in the pupillary size and clinical examination. You must think about hemorrhagic cerebral vascular disorders possibility. You have to go for anticoagulation for patients who have got strokes, and anticoagulation free dialysis, that is heparin free dialysis, as well as to take off the antiplatelets medications which will thin the blood. We have to look into the drug chart for that. When we talk about peripheral disorders, we spoke about there is something called as a mononeuropathy, that is a single nerve involvement like carpal tunnel syndrome, where your median nerve is getting compressed. So here what we do is we give some steroids, some decompression, surgical decompression is the best. Many patients carpal tunnel syndromes have reversed after renal transplantation and optimal dialysis. We spoke about ischemic monomelic neuropathy, that is a mononeuropathy itself. We said that we need a surgical correction of the vascular access so that we can prevent the ischemia. The techniques of which we use in Steele syndrome, same applies here. We can use distal revascularization and interval ligation like drill or proximalization of the arterial inflow. You had uremic polyneuropathy. You discussed about vitamin deficiencies. You can use anticonvulsants, good dialysis, and renal transplant is the final treatment. Miscellaneous topics, we didn't cover uremic myopathy, but it generally means nothing, but you have to have a good exercise program and vitamin D supplementation and good dialysis. Uremic pruritus is also considered as a neurological symptom for patients who are having dialysis, where we again have to, whether it is uremic pruritus or encephalitis, the idea is to have good control of good hemodialysis, good quality dialysis, good biocompatible dialysis membranes, and good control of phosphorus and parathyroid hormones. And lastly, we discussed about restless leg syndrome, where we spoke about the use of dopamine agonist. We used benzodiazepines and propranolol, and we mentioned that restless leg is something which is very common in your units, but we do not pick it up because patient has same complaints of cramps, leg pull. Sometimes they mention about insects walking over, and they generally respond very well to these drugs. So to sum it up, the take-home messages for the day is that headache, seizures, and weakness have to be taken seriously and evaluated for cause. We cannot take simple symptoms very lightly. Hold dialysis and stop heparin in patients presenting with neurological symptoms till further clarification of cause. Because we don't know whether that little seizure or little blurring of vision is whether because of the bleed in the brain. Imaging is very, very important. Every time the patient will request you, we don't have money to do CT. And we also take a call clinically that there may be nothing, but there are many times we fell into problems because of that. And patient had a large bleed, which was initially small. So CT minimal, at least to rule out whether there's a bleed so that you can give heparin or not in the next dialysis can be clarified. An MRI brain in situations like we discussed dialysis disequilibrium, we discussed about posterior encephalopathy because of hypertension and press-like symptoms. Drug chart needs to be checked regularly to look for drugs causing neurological symptoms. It is one thing which we all miss. We may think that the patient is one patient presented with wobbly symptoms, sleepiness, was not feeling well, nausea. He's saying dialysis has made the patient weak, but actually, patient was at a dose of 300 milligrams of gabapentin, which was a reason for the patient having these symptoms. There was a patient who was presented with vertiginous symptoms like a vertebrobasilar insufficiency. So patient complained of continuous vertigo non-stop every time. And all possible drugs were given, but it was not controlled. The patient will again come with vertigo as soon as the drugs are stopped. And later on, we found that the gentamicin, which we were giving, that's an aminoglycoside, which we were giving in the catheter lock was the reason, the side effect of which is the cochlear toxicity, which caused the patient to have these vertiginous symptoms, which was not picked up by any imaging, stopping of which the patient responded very well and the symptoms also faded off. So it is very important that we go through the drug chart. I think with that, that I close my talk. Thank you very much and Happy New Year to all of you.